Okay, and welcome to another lecture, I suppose, on Hobrough.com, where I'm going to talk you through shockwave therapy and the back, spinal treatments. If you want to get more information, you go to Hobrough.com, which is maybe where you're viewing this, or maybe you're on YouTube. But if you go to Hobrough.com, there's lots and lots of resources there on topics all about shockwave therapy. So this one, extracorporeal shockwave therapy for spinal treatments. So let's think about the problem first of all. 30 million days lost from work. I mean, this is back in 2011, so we're 9 years ago. I'm sure that number is greater now than it was back then. But you can see the size of the problem. And this is a result of musculoskeletal issues. Low back pain is the largest single cause of disability in the UK. And I'm sure those of you watching from around the world will find that these numbers are equally as disturbing in your country as they are in the UK. So what's the prevalence? So it's been estimated that it would be as high as 84%, the prevalence of low back pain, 84%. One of the things that we know is that about 80% of the population will suffer a significant form of back pain, which will stop them doing their usual activities and potentially stop them going to work. So the prevalence of chronic low back pain is around 23%, and 11 to 12% of the total disability in the population is being caused by low back pain. So we can get an understanding of the sheer volume of the issue and why so much research is being developed into the ways in which we can treat low back pain. So the N.I.C.E Guidelines, which is where in the UK we are a little bit beholden to them. They take all the research and they make a decision about what things should be considered, should we say, evidence-based, and what things perhaps shouldn't be used based upon a low level of evidence. And there is a new kind of draft guideline that is recommending exercise in all its forms as the first step in managing low back pain, which is great. We want to get people moving. And before we get into different types of modalities or different methods of achieving this, I know that on one side we've got people like Lorimer Moseley, who is an absolute champion of the pain science, who would be perhaps more against things like the passive treatments, some of which we're going to talk about, and much more in favour of what we should say motivational interviewing, getting a good subjective and helping change the person's perception around their pain. And that is brilliant and it's great science, and I think it should be employed in all of our back pain discussions with our patients. Massage and manipulation by a therapist should only be used alongside exercise because there's not enough evidence to show how they're of benefit when used alone. So this would be moving away from the pain science Lorimer Moseley viewpoint and adding in some passive modalities. But even in our N.I.C.E guidelines, they're saying using this alongside exercise would be something that they would consider to be viable. But they're quite right. There is some controversial evidence around how passive therapies might be utilised. Now let's make one very, very clear distinction here. Most people will feel significantly better after massage or different forms of manipulation or manual therapies. But where the issue is can that be shown to have ongoing long-term benefit? So the science is saying that we can't actually stipulate significant evidence say that has a long-term benefit. If you're a patient who's in absolute agony and has come to see you because they just want something to be done, then the N.I.C.E guidelines are saying, hey, this is fine, but they must also be doing some exercise. And I really truly believe in this bringing together of what we know about the pain science, which has been shown to have some reasonable science to suggest it has a better long-term outcome, and using something which actually helps the person in the there and now. And as long as they're not going away thinking this massage and manipulation or whatever is now going to eradicate my problem, I don't need to think about my erroneous views on pain, then we are actually getting somewhere. And it's the skill of the practitioner to blend those together to give them some short-term benefit, gets them moving more. Remember, that's our first thing, is to get people exercising. So it's very, very difficult to ask someone who's in abject agony to go ahead and exercise. If you can relieve that slightly, increasing the blood flow, increasing their confidence, increasing the range of movement, as long as you're not creating a reliance and a dependence upon them seeing you week after week after week for those therapies, then it's a really, really good way of kick-starting that. Now think about the patient who's in agony, is thinking, this is only getting worse, this is never going to get better. These are sort of thought processes. If you've had horrible back pain for any length of time, you start to believe that it's not going to get better. And so if by giving a small tangible result in the short term gives them that belief that this might actually have a chance of getting better, they can move a bit more freely, and they understand the education around exercise and movement, then surely we're going to get a better outcome, a better buy-in at the very least. One of the things about back pain is people are always saying, well, where's it come from? Is it my posture? Poor science around posture. Is it because of the big heavy thing I lifted? People talk about, horrible. I was just on the internet today trying to take someone away from this fact that they mentioned on their back pain and their disc, they were fearful of it exploding. I mean, we need to understand that educating people about the fact that just isn't going to happen is the first step to getting them better. But we're actually talking about this in terms of back pain. It's kind of the same as flu, right? It doesn't distinguish about who's going to get it. It comes along seemingly many times for absolutely no reason. But unlike flu, people assume they're now weak and more susceptible to having back pain ongoing. Whereas when you've had flu, you come away from it, you kind of go, well, there's no reason why I'd catch flu again. So it can be quite nice to try and make that distinction for your patient. So explaining to them that there doesn't necessarily need to be a reason. They're in a big group of 80% that are going to potentially get this in their lifetime, and they will get through it. There is an end point, and that what we can do is some short-term intervention and also some long-term intervention. But we need to get you movement. Movement is therapy. So within this draft guideline, they decided that acupuncture was out, that paracetamol was out, and that instead they would use non-steroidal anti-inflammatory drugs. I question that. I think that non-steroidals are very difficult on the stomach, and I'm not sure actually how well they do work. If they do give the person some pain relief and they're taking it with a little bit of food, then potentially that's good. But the number of people you see where they say, I've taken non-steroidals, I've taken paracetamol, it doesn't seem to be doing anything for me. But what is good is this notion of taking end-of-life care drugs, opioids, such as codeine. Take those out. They were not designed to help people with back pain. However, if these first-line drugs don't work, then possibly we go to some stronger medication. Talking therapies. So combining physical and psychological treatments are recommended for people that have not seen any improvement in their pain. Now, why do they need to not see any improvement? We can start this education really early on. Previous treatments haven't made any difference, and they've got significant psychological and social barriers to recovery. These people, yellow flags we call them, where they've got a sort of sociocultural issue or barrier to them moving forwards. Psychologically, they're struggling with this fact. We need to try and get these people back on board. So what can be done? Research actually is it research or is it dogma? Some of the things that we would currently use for low back pain, the research has been shown to be quite inconclusive. The N.I.C.E Guidelines support manual therapy and exercise, which is good, but you can only use manual therapy in conjunction with exercise. But I wanted to open your eyes a little bit to using the spinal and peri-actor attachments on a shockwave therapy machine, and also to look at the research that's been done by Thomas Nedelka on the use of radial shockwave therapy against something which has really low efficacy, which is spinal facet joint injections. So Nedelka found that shockwave was more effective than a facet joint injection and had less complications. This is my favourite study of pretty much all that I've ever read. It's from 2014, and it's incredible to think that we're holding something which, yes, is a passive therapy, but that we can make an equal or greater difference to a facet joint injection. And if we can just kickstart that process of getting that person moving by doing something like shockwave, then this has to be of benefit to get them into the exercise model and to be able to start talking to them about why their pain is there and the best things they can do to get rid of that pain, and the fact this isn't an affliction because of necessarily something they've done. I'm very, very proud that Thomas Nedelka has asked me to be involved, albeit in a small way, in his most recent study, which is currently going through peer review, which looked at the same study that he's done here with radial shockwave therapy, and he's used focus shockwave therapy. And what we found is greater efficacy, greater results, improved outcomes. And I do really believe that when you get onto focus shockwave therapy and using it in this way, you will see a massive improvement. And just for the people that might jump on top of this and say we shouldn't be creating a reliance on these sort of therapies, if you're giving your patient pain relief and they move more and they get better, then the bias that some people are using to state that all of these passive therapies are bad, that they are just simply wrong. And if the factions within the therapeutic community could stop warring over who is right and who is wrong and take a patient-centered approach, listen to your patient, find out what it is that they really feel they need, challenge their beliefs, but bring those things together and remember that we don't just denounce many, many, many years of research in favour of the kind of more modern approach. And I think that we should use as many kit bags, as many tool bags as we've got, and just ensure that you as a practitioner are not enabling your patient to have a reliance on you or a reliance on these therapies, but we are using them in a very, very specific way. And we've spoken about injections just now. I qualified fairly recently in the use of steroid injections and the like. And again, the evidence can be quite poor on those. And the one thing that I find strange around the evidence for injections is that people are hung up on the fact there's no long-term benefit. But if you've got someone who can barely move their shoulder because they've got an inflamed subacromial bursa, and you can make an almost instant difference in a huge percentage of those people by putting a little bit of steroid in there and calming it down quite quickly, why can that not be seen as being very effective in the short term? Why does everything have to try and show a long-term benefit? What is wrong in this scale of the things that we can do in giving a very real, a very tangible short-term benefit, as long as that's exactly how we're describing it, and we're saying, look, we're going to give you a chance to get on with the exercise that you need to do to get rid of this long term. But you can't do them at the moment because you're in too much pain. So guess what? We're going to do something that's going to give you a window of 6 to 8 weeks of pain reduction, and you're going to be able to get on those exercises. By the time that pain reduction is in effect wearing off, for want of a better term, they will be 6 to 8 weeks further down the line, and probably those two lines will bisect each other at the point at which their pain is now reduced, their range of movement is improved, they are getting about their ADLs, and they might not even notice the fact that the injection hasn't worked because they've been in a position to improve themselves. So let's look now at the future research. So shockwave therapy has potentially become the first line non-invasive treatment for low back pain. And it may well be providing a very, very good short-term benefit. It also has the ability to create longer-term benefits. Many, many shockwave studies have shown improved benefits at 1 to 2 years. And I personally, as others, have been quite critical about that. But when you look at a lot of the surgical outcomes, they look at surgery at the 1 and 2 year timeline to make sure they have had a long-term success. So one of the reasons why we look at shockwave over this period of time is it is often seen as something that could be done instead of surgery. It is non-invasive. Well, sorry, it's non-surgical. I suppose I've fallen out of love with the term non-invasive because it is doing something, but it's non-surgical. As we know from Nedelka, facet joint injections are less effective than shockwave. Exercise and the biopsychosocial model, I believe, are and should remain frontline treatments, but I feel very strongly about a combination of exercise, education, and also in the early stages, pain relieving modalities, and all of that can be proven to be successful. So, Nedelka's paper, it's here for you if you want to take a note of it. His dad, during Nedelka, was also involved, and 3 other authors. Its main objective was to look at the lumbar facet joints and compare shockwave with the injection therapy. The efficacy of shockwave was not yet studied in facet joint pain at that time, so in 2014 this really was breaking new ground. A reasonable number of patients divided into groups, and shockwave therapy had shown better long-term results compared to facet joint injections, and didn't observe any adverse effects or complications in the shockwave group. Moreover, the shockwave had significant long-term improvements in daily activities, and that, I think, is ultimately where we're trying to get all of our patients. So I mentioned right at the beginning, I wanted to sort of introduce the spine actors and the Peri-actors. So these are the spine actors actually in use, and you can see them, if I can talk over the noise, working on a 45-degree angle. You've got some contact medium there in terms of gel, and you work over possibly a 3-inch section, and you've got a reasonable amount of pressure, but not too much, and you work up and down the facet joint. Now, one thing to note here is that you are not providing shockwave. This is not what Nedelka's study was showing. We know that you can use the radial device and you put it straight over the facet joint and you spend 1,000 shocks on each facet joint and you move in time, so it's much more static treatment. But if you want to look at your patient in terms of getting to the point where we can actually even just deliver some hyperstimulation anesthesia, where we can loosen off some of that tissue around the lumbar spine and then use radial over the facet joints, and moreover now with the new research actually use focus shockwave over the facet joints, you will improve their ability to move, you will reduce their pain, and you will get a really, really good short, but the Nedelka study is showing actually quite a good long-term outcome as well. And if you put that in and alongside their gradual increase in exercise, their specific strengthening exercises, their general walking programs, Pilates, whatever else you want to give them, then you're getting them moving, you're getting them exercising, but you're giving them a window of opportunity to do so. And this is really very good. And the NICE guidelines state that manual therapy, as long as it's being used alongside exercise therapy, is well understood and accepted. Now, there are different attachments here, so you can use one on the lumbar spine, the thoracic spine, and the cervical spine. You can also, when we get on to the Peri-actors, which is a different end piece, which is used a bit like a deep massage tool, I suppose. And you can help, as you'll see here, locate the trigger point. So by moving through, a bit like a divining rod when you're looking for water in the olden days, you're actually moving this around the soft tissues, and you'll find it actually quite easy to come across a tight band of muscle, a trigger point. When you've located that, we've got a variety of different tools that we can then put on, like the severe here, where we can go straight into that trigger point. And when you've done a combination of the spine actors and the Peri-actors, and you change the Peri-actors around to get into that trigger point, and then you're using the standard radial shockwave, and then if you've got it, moving on to focus shockwave, I defy you to not have an incredibly happy patient. Now, I do an entire 45-minute interview with Thomas Nedelka on paulhobrough.com, specifically on this point, and talking around shockwave, talking around his study and the benefits for low back pain. So I'm sorry if by doing this I've perhaps upset the people that are purely on the biopsychosocial model. I apologise to the pure manual therapists if you don't really want to invest time in the biopsychosocial model, but I'd urge both of the sides of those two polar opposites to come together, meet in the middle, understand that in the NICE guidelines this is perfectly acceptable, and go back to a patient-centred approach where we can use all the tools in our kit bag to get the very, very best result for our patients by combining manual therapy, the biopsychosocial model, motivating our patient, but ultimately getting them moving by taking a slice of the research, by taking a slice of our experience and expertise, and by taking a slice of the client expectations. And when you jumble all that together, this protocol that I've just shared with you, I think is a really, really good one. And I'd love to see somebody take this on scientifically and put it against purely biopsychosocial pain science and purely manual therapy, because I have a strong feeling from my own anecdotal evidence and those that I've worked with that we could have a good outcome for this protocol versus the others. So I look forward to people's views and thoughts on this, and hopefully it generates a reasonable amount of discussion. Please do go to paulhobrough.com, listen to the Nedelka video, and you might find yourselves perusing around looking for other things of interest.